focusing my presentation basically onto the day-to-day daily challenges that a technologist faces in a busy CT department while performing the CT abdominal imaging and how to resolve them. I will not be talking about in my presentation the various radiation protective mechanisms and the protocols. I won't be talking about the technical the technical details of the CTs, and also not on the contrast dosages and the pump injector protocol. I will not be talking about these. So my main objective is, the first and the foremost is the significance of history taking, which Kiran has very beautifully outlined, the art of history taking, which we have long forgotten. We need to revise that. Counseling and reassurance before, during, and after the procedure. The choice of contrast, oral contrast medium, a very interesting debate. And we all are still confused which type of contrast medium, oral contrast medium that I'm talking about, should be used in what type of cases. And then tailoring the technique in special circumstances, a very interesting and exciting thing to do in a busy CT department in when various type of cases are coming for imaging. Special precautions that are needed for intravenous contrast injections, instructions especially related to females and children, and last of all, the data processing and filmmaking. So to start off with the history. In our department, the history performer is usually filled by the resident. And it is my view, and it is of paramount importance, that before starting an investigation, the indication of that investigation should be established in the history performer. And I urge the technicians, since I'm focusing my attention to the technicians here, that they should, before starting the procedure, should be clear in mind that what type of questions the physician has in his mind. That is, what is the indication of the study. And if possible, not in every case, if a brief history is taken by himself, by the physician, by the technician himself, it's a good practice, because it can clear the ambiguity in your mind before doing the study. And at the same time, it develops a bond of trust between the patient and the technician during the study. And then lastly, counseling and reassurance, very significant, because it is important to explain the procedure to the patient before, during, and after the study. And all the questions of the patient should be answered patiently, because as the patient is less apprehensive, he will be more attentive to your instructions during the study, and the result will be a better study for the reporting for the patient, for the radiologist. Now I come to the interesting topic, that is the choice of oral contrast medium, positive contrast medium or negative contrast medium. By positive contrast medium, I mean that the iodinated water-soluble contrast medium. And by the negative, I mean simple the water. It is, there is a lot of variation in it. Different people practice differently based on their experience, but it is generally advised that a positive contrast medium can be fairly used in emergency cases like perforations and obstructions. I have given you one example here. I've shown one example here. This is a patient, and we can see the dense contrast in the stomach, and we see the contrast outlining the right lobe of the liver here. In the peritoneal cavity, we see the fluid and then the air here. So pneumoperitoneum is there. And just a little caudal slice, we see the contrast active extraluminal spill from the second part of the duodenum and its accumulation along the undersurface of the liver. And in the coronal image, it is very beautifully shown the tract leading from the duodenum and the accumulation of contrast along the liver surface. So the significance of the positive contrast medium in a suspected case of perforation, because the surgeon would like to know, he is already clinically suspecting a perforation, he would like to know the site of perforation, which can be nicely highlighted here. Then the second case, this is another case of intestinal obstruction. In intestinal obstruction, again, a dense contrast, oral contrast has been given, but due to the obstruction and fluid-filled dilated gut loops, we don't see much of the contrast filling the gut loops. But in this case, there is another important thing that needs to be kept in mind, that no contrast should be given per rectally, because when the rectal contrast is given, the point of transition, which is what the surgeon wants to know, where the obstruction is, what is the cause of obstruction. With the rectal contrast given, that point of transition can be very easily obscured. Like in this case, if you can see, these are the dilated gut loops, and which are dilated proximally, and then we see this narrowed, strictured small segment, and distal to that segment we see this collapsed small and large gut loops. So emphasizing the point of transition, which is this strictured narrowed segment of the small gut loop, which the surgeon would like to know. There is one condition, emergency condition, in which a negative contrast medium, that is water, can be very helpful. That is, if there is a suspicion of GI hemorrhage. Because in GI hemorrhage, if there is an active extravasation of contrast into the water-filled lumen, it is very nicely shown. I have shown you two cases. In this case, we can appreciate the active spill of contrast into the lumen of the stomach, and the stomach of the lumen is filled with water, so the contrast extravasation is very nicely shown. Another case, water filled large cut, the plain image, and then in the contrast enhanced, basically taken in the arterial phase, we can see the active spurting of the contrast into the water filled lumen of the stomach. So this is one emergency condition in which a plain water negative contrast can be helpful. Now, coming back to the elective cases, it is recommended that usually in elective cases, a negative contrast can be more helpful. I've shown you three examples. Here, this is a patient with CA history or a suspicion of CA stomach. We see the water-filled stomach here, and we can appreciate the beautifully, nicely enhancing walls of the stomach. And over here in the posterior wall of the stomach, we see this broad-based polypoidal mass lesion projecting into the lumen of the stomach. We can appreciate its broad base, its adherence with the wall, and its relation with the lumen very nicely. Another case, this is a case of inflammatory bowel disease. CT enterography has been done here in this case. We see the fluid filling the small gut loops and the enhancing walls of the small gut loops. And over here, this is a segment of the small gut loop which shows intense enhancement of the mucosa and then lobulated submucosal edema. The narrowed lumen is filled with water. So all this contrast is very nicely enhanced with the water in the background. And we do see this engorgement of the vasa recta as well. So this is in case of inflammatory bowel disease. Another patient with the pancreatitis and pancreatic necrosis, and we see the plain fluid in the stomach, and we see the fluid collection in the pancreas, and the intervening plane between the two structures are very nicely elucidated in this slide. So just to emphasize the significance of a negative contrast medium, that is plain water, in elective cases. Now, patient preparation. This is a very important slide to me, the liaison between the radiologist and the technologist. This is very important in achieving good results. Because in certain situations, the things, they don't go according to the plan. Patient comes with a kind of symptoms, the performer or the physician request forms come to you, but when you do the study, you see certain surprises which you don't expect. At that moment, a liaison with the radiologist is important, how to tailor the technique according to that situation. And many times the radiologist is not available at hand, so the responsibility lies on the technician. And I believe in that case, the technician should be intelligent enough, experienced enough to alter and tailor the technique in the benefit of the patient to acquire the maximum result. So I have explained few examples just to elucidate my point. For instance, a request form for a CT abdomen or pelvis has come, and during a scanogram or even doing a study of an abdomen, you find something wrong in the pelvis. Extend the field of view so that whole of the pathology is nicely elucidated, rather than going by the book because no, just the abdomen has been advised, so I'll just do the abdomen. No, just extend the field of view a bit in the benefit of the patient, so that the patient time is saved and he gets a better information for the clinician. Secondly, for instance, the patient comes for the plain CT scan. Mostly this is done for KUB renal colic, in a suspicion of renal colic, and there is an incidental finding of a mass or any other lesion which is causing the simulating as a renal colic. I believe a contrast study should be done, of course, following the protocol of establishing the renal function test and also informing the clinician. But I believe that a contrast study should be done then and there, so that a complete study is given to to the patient, and his time is saved, and his treatment can be started immediately. Then installation of the rectal contrast in suspected cases. We don't give rectal contrast on routine basis. If it is to be given, it is usually suggested or advised in the history performer or in the request form. But many a times while performing a study, some situations arise. We see a pathology in the pelvic region, and this rectal contrast has not been suggested initially, but it should be given to clarify that pathology or malignancy and its relationship with the rest of the structures. I have given selected few examples, like in this particular case, this is a plain water has been given per rectally, and we can see a lobulated growth along its anterior wall, and it is extending beyond the confines of the rectum and involving the prostate. So this is another example. We can appreciate here that this is a patient in which we can see that there is contrast has been given per rectally, and a recto-vaginal fistula has been outlined here very nicely. Another example of a recto-vaginal fistula with the rectal contrast outlining the vaginal fistula. Then, of course, there are many a times we see post-operative patients in which colostomies has been done, and there is a debate from where the contrast should be given. Again, the understanding why the study is being done, why the surgeon has advised this procedure. Most of the time, they want to do the reversal colostomy, and they want to see the patency of the distal limb. So in these cases, the rectal contrast, preferably from the rectal side, should be given to see the patency of the distal limb. If that is not possible, from the colostomy side, from the distal limb, the contrast should be given to outline the distal limb. So the idea is to have the knowledge of these type of variable, different circumstances that can arise in a busy department, which is different from the routine study, and how to handle them and how to tailor your technique according to the need of the requirement. Now, the important thing again is something which is very important to understand, the special consideration that we should kept in mind while we are giving intravenous contrast injection. Importantly, understand knowledge of comorbids the patient has, like ischemic heart disease, diabetes mellitus, and the type of drugs he's taking with it. It was previously, this was the knowledge that metformin can cause lactosidosis, so it should be stopped before the procedure. But nowadays it has been suggested that it is not the case. But still, the idea of type of medications the patient is on, and if there is any risk suspected, the physician should be alarmed about it. Similarly, about hypertension, the baseline blood pressure level at the time of study while you are performing the CT scan, that should also be kept in mind. Then secondly is, of course, the renal function test. When we are giving the intravenous contrast, the knowledge of how the kidney is functioning, and we usually assess by knowing the urea and creatinine levels. But nowadays, estimated GFR value is a better recommended tool to know understand the functioning of the kidney, because it not only covers the functioning of the kidney, but it also takes into account the age of the patient, the gender of the patient, and the race of the patient. So that is why it is suggested to be a better tool of estimating the renal functions than simple mere urea and creatinine levels. Lastly is the hydration status of the patient. Usually, the patient should be well hydrated before the study, contrast study, until and unless there is some special restriction of fluid intake by the physician, which we all would know definitely before the study. The patient should be well hydrated, 6 to 8 glasses of water within 48 hours before the study. And after the study, patient should be advised to take ample amount of water for at least 48 hours. And in high-risk patients who have got borderline renal functions or have a previous history of nephrotoxicity, it is preferred to have fresh RFTs after the contrast study within the 48 hours to rule out any contrast-induced nephrotoxicity. Now, the special precautions that are to be kept in mind by the technician in certain situations, like when you are imaging a lady of a childbearing age. It is very important to rule out the pregnancy in a childbearing age when you are performing a CT scan of the abdomen. In our department, usually it is assessed while the resident is taking the history, the LMP date is established, but if there is any confusion, beta HCG levels should be done. And the technician should also go through the history performer to see that all the points and all the pertaining details, especially related to this thing, has been fulfilled in the performer. And then, of course, the technician's job is to taking care of the patient privacy, females especially, keeping the proper decorum while instilling the rectal contrast and all that. This is very important. And then special instruction related to the children. This child here is looking so cute and is lying still, but that is not the ideal situation. We all know that. I think he's just posing for the picture. But we all know that the children, they can be very restless and can be quite a challenge for the technician while they're performing the study. So it is important to calculate the contrast dosage, minimize the radiation exposure, as Kiran has already pointed out, but not at the cost of compromising the study. And where the need is required, which is most of the time is required, is to give sedation to the patient, but that should be done under strict monitoring, by the doctor. So these are the two important situations that should be kept in mind while performing the CT imaging. This is the most important slide. Filmmaking in our country. Now, even now, we are giving films to the patient, whether we are performing CTs or MRI, while in certain institutions, it has been shifted to DVD. And the clinicians, they see the data on PACS, which is, I think, a better practice. But still, films are in fashion even now, and people do make films. So I believe that the number of CT films that are being made, they should be kept minimum, restricted, and they should elaborate the pathology that has been mentioned in the radiology report. Many a times the physician, they come to us with this problem that, okay, you have mentioned this mass or this lesion or this infarct or whatever, but I cannot see it on the film. So for that matter, it is important that the films that are being made, they should nicely elucidate the pathology that has been mentioned in the report. This is a dilemma which needs to be resolved, whether a radiologist should sit with the technologist to make the films, or resident, or whatever. But this is something which is a problem in every radiology department we are facing, and this needs to be resolved. Few steps that can be taken in this direction is that the pathology, if you can identify the pathology, you can elaborate it in the form of, these arrows. You can point out these arrows indicating the pathology. You can label the pathology as well. This is an interesting way, because it will make the clinician at ease, and he will understand the pathology better. Then, of course, knowledge of making the 3D images. This is another way of presenting your data. Usually, in ideal circumstances, the application expert, he will make the 3D imaging. But nowadays, I have seen the technologists, they are very well versed in making the 3D images. And I think this is a very good way of representing your data, because your clinician is quite comfortable with these type of images, and you can point out any aneurysm, malformation, or mass on these images. So this is a good way of presenting your data. So at the end, I would like to conclude my session, especially pointing to the technologists, that you are very powerful, provided you know how powerful you are. Because I believe that the radiology department, it revolves around how wonderfully the study has been done. Thank you very much.